So thank you for those of you who I'm sure tried very hard to join this talk today. We have Dr. Kwan, who's one of our stroke attendings here at UAB. We chose this topic in anticipation of the neuro hospitalist kind of stroke service starting hopefully this summer. So it's something we're all going to need to be very familiar with as we go forward. So we invited Dr. Kwan to come and talk about some updates in stroke and kind of practical management things that we as all hospitalists need to know. So with that, I'll let you kind of take it away.
Thank you. It's my pleasure to give this talk on clinical updates in stroke care for the hospitalist. I tried to focus on practical things about stroke care, and I could spend hours and days talking about specific points in this talk. So if you would like a more detailed presentation on a specific topic, please feel free to let me know. I would be happy to talk more about stroke. With that, I will get started. And if you have any questions in the middle of the talk, just shout it out. Yeah, all right. I have nothing to disclose. Um, so today we are going to go over when to activate a stroke code. I'm going to talk a little bit about acute interventions for hemorrhagic and ischemic strokes, basics about stroke imaging, and then post-acute hospital care and secondary prevention strategies. So starting with a stroke code. You're probably all familiar with the concept that time is brain and every minute lost is brain lost when it comes to a stroke. So you definitely want to be quick when it comes to stroke care because every minute that the brain remains unperfused, that's brain cells dying. And so the whole purpose of a stroke code is to, first of all, identify if this is a stroke that's going on, and then try to stop the stroke from progressing and try to reverse the course of the stroke so that we can get the patient back to being normal again. And if that is not possible, then at least try to minimize the brain damage and morbidity from the stroke. So when should we activate a stroke code? Um, Whenever there is any sudden focal neurologic symptom or any acute unexplained mental status change, go ahead and call that stroke code as quickly as possible. Stroke codes are specifically not for incidental finding of a stroke on imaging or change in mental status due to a known cause. Like if a patient is admitted with hypoglycemia, and you know that they are drowsy, definitely don't want to call a stroke code for that. And it's not a way to get you stat imaging, but have a very low threshold to call a stroke code and try to call it as quickly as possible. There's a few things that we definitely need to know when you activate a stroke code. And these are the two things are last normal time and the symptom that prompted the stroke code. And these are not things that we can find out from the chart. We need to know from the person who activated the stroke code. So please let us know when, the best estimate possible as to when the patient was last seen normal at their baseline, and then what symptom prompted the stroke code. And then additional information that would be very helpful to know is past medical history, including any stroke history. Their vascular risk factors, any recent surgeries or procedures that might influence our decision making, and any recent bleeding. And obviously, if they're on an anticoagulant or antiplatelets, it would be helpful to know that. Any CNS altering medications would be great to know. And when a stroke code is called, then a neurologist, usually a neurology resident, will be at the bedside very quickly and they will do an exam. And you don't need to know the specific points of the NIH stroke scale, but some things to pay attention to would be mental status. Are they drowsy? Are they alert? Are they unresponsive? And then eyes. And this is something that if you don't check for it, you very often miss it, but do they have a gaze deviation? Do they have normal eye movements? Do they have a visual field deficit? Um, and then you obviously want to look at their face and arms and legs and see if there is any droopiness, any numbness, any ataxia in those areas. And then language and neglect are important things. You want to ask pointed, direct questions about language because patients with aphasia can fool you and pretend that they can answer questions when they actually can't. And then neglect, you want to see if they're ignoring one side of the world, one side of their body. And specifically when it comes to a neurologic exam, I wanted to really highlight these 4 signs to look for: aphasia, neglect, visual field deficit, and gaze deviation. These are what we call cortical signs. And you get these symptoms only when the cortex is involved. You would not get them with a small lacunar stroke. And when you have cortical involvement, these are strokes that are going to change a person's life. These are these are things that you see when you have a large vessel occlusion, and usually a very large life-changing or sometimes life-ending stroke. So when you see aphasia, neglect, visual field deficit, and gaze deviation, please let us know that this is what you see. You're concerned about a large vessel occlusion, and we will expedite getting CTA, CTP, alerting neurointervention, etc. Obviously, there's more cortical signs than these 4, but these 4 are the ones that you can check for very quickly. Obviously, you can't check like decision making or judgment, things like that, emotions or inhibition very quickly, but these 4 things you can check for very quickly. All right. There are a lot of things that mimic a stroke. And this is just an example of the numbers from January of this year. There were 186 stroke code activations during the month of January. And as you can see down here, only 73% of them were actual strokes. So more than half of all stroke codes are not actually strokes. And that's okay. We would rather have more stroke codes than more stroke mimics, and have a stroke code called for something that's not a stroke rather than miss a true stroke. So lots of things can mimic a stroke: migraine, seizure, and metabolic things. Hypoglycemia, hyperglycemia are probably the most common 3 things. But then things like hypertensive emergency, drug toxicity, alcohol intoxication, hepatic encephalopathy, Bell's palsy, these are things that can mimic a stroke. And these are all legit reasons to call a stroke code, because even a trained neurologist can't tell sometimes. And that's why we do the evaluation and the imaging and things like that. Okay, this is the fun part, the acute intervention. What can we do to reverse the process, get the patient back to being better? I'm going to start with hemorrhagic stroke because we're kind of limited in what we can do for hemorrhagic strokes. Once the blood is spilled, it can't be unspilled. But we try to minimize the morbidity and the brain damage from a hemorrhagic stroke. The 2 main interventions that we can do in the hyperacute phase is blood pressure control and coagulopathy reversal. There's surgical treatments, there's drain placement, there's craniotomies. Those will be done, when the patient is on a neurology or neurosurgery service. That involves multiple teams making the decision. But these are the things that we can do in the hyperacute period: getting the blood pressure down and reversing whatever coagulopathy that they may have. Blood pressure, a good range is somewhere between 140 to 180 systolic. You don't want to correct their blood pressure too drastically, too quickly. And there were clinical trials done to see if getting the blood pressure down below 140 is going to be more beneficial in stroke outcomes, and it was not the case. There was no benefit in mortality or or functional outcomes. And there was an increase in renal insufficiency when we got the blood pressure down too quickly. And so somewhere in the 140 to 180 range is pretty good. Depends a little bit on where you're starting from. If you have a patient with a blood pressure in the 220s, you probably want to get it down to like 180. If they're already coming in at 180, you want to get it down to 140 or 160. Coagulopathy reversal, for heparin, warfarin, dabigatran, apixaban, and rivaroxaban, we have specific reversal agents. For aspirin or antiplatelets, there's not really a specific agent. There's some talk about using DDAVP in specific cases, but you definitely don't want to give platelets for patients who are on aspirin or Plavix unless they have a known platelet deficiency. Again, there was a clinical trial and we found that there is no benefit and there actually could be harm if we infuse platelets just because they're taking an aspirin. A note about warfarin reversal, vitamin K, usually if you have an intracranial hemorrhage, you would give it IV, but it doesn't work very quickly. So that's why you want to give additional PCC or in some cases fresh frozen plasma. FFP is slow, you have to thaw it, it's a lot of volume, so we prefer giving PCC if that's available. And then Praxpine and Dexa, these are pretty expensive medications, so you don't want to give it if you have a tiny little hemorrhage, like you see in this picture here. You want to have a reasonably large or significant hemorrhage that could be life-changing or life-ending, and you probably wouldn't want to give it for somebody who has an obvious non-survivable hemorrhage either. All right, so that's it for hemorrhagic strokes. Ischemic stroke, this is where we get really excited. This is when we actually get to flex our muscles. We actually have weapons to use to reverse the process. It's very fulfilling. First of all, starting with thrombolysis or IV TPA, tissue plasminogen activator, also called alteplase. This has been around for a little over 20 years, probably. It used to be the only weapon that we had. Now we have thrombectomy, which I'll talk about next. But TPA, it's still very useful. There's inclusion and exclusion criteria, obviously, for this medication. Inclusion is you have to start with a disabling stroke. So if you have a really, really mild stroke, like numbness in a finger or something, you don't want to take the risk of giving TPA for the benefit of reversing that. But if you have a disabling stroke, then that's when you want to give TPA. You need to establish that there is no hemorrhage on CT and you have to be within 4.5 hours. There's a little bit, initially it was approved for within 3 hours, and then there were clinical trials that proved safety and efficacy for up to 4.5 hours. There's a few additional criteria that I put in small letters here because we don't really pay attention too much to that additional exclusion. Like if a patient is over the age of 80, we would still give TPA if they're having a disabling stroke. So this is, something to keep in mind because the longer the more time passes from stroke onset and the older the patient is, the larger the stroke is, there's definitely a higher risk of bleeding. And that's why the additional inclusion and exclusion criteria exist. But for a person having a disabling stroke, we're probably going to have a discussion about the risk and the benefit with their family member if they're available, and then end up giving the TPA if we feel that it is reasonable to do so. There are many exclusion criteria for TPA, most of which are to try to exclude patients who are at a high risk of bleeding, basically, because bleeding is the most feared complication of TPA. And we very quickly review these criteria with the family member or with the patient if it's possible, and then we give TPA if we can. The dose is zero 0.9 mg per kg, maximum 90 mgs, first 10% given as a bolus over a minute, and then the rest given as an infusion over an hour. And then there's a very strict post-TPA protocol, which is an order set. And basically, we check vital signs and neurochecks very frequently. It's every 15 minutes for the first 2 hours, and then every 30 minutes for the next 6 hours, and then every hour for the next 16 hours. And that is to really closely monitor the patient in case there is a decline in neurostatus or angioedema or bleeding. And for the first 24 hours after TPA, you want to avoid anything that can make a patient bleed, basically invasive procedures, intramuscular injections, nasogastric tube if possible, um, to try to minimize the risk of bleeding either in the head or elsewhere in the body. There's a lot of talk about tenecteplase, and that was a hot topic in our International Stroke Conference last month. And a lot of centers are making the switch or thinking about making the switch to tenecteplase because it's easier to give. It's just an injection. There's no hour-long infusion with tenecteplase. It's a little bit more fibrin specific, so less worrisome for systemic bleeding or systemic coagulopathy complications. And it's been proven to be as good as TPA, if not maybe a trend towards being better. So we in the stroke division are talking about making that switch. So look out for a switch coming probably in the next few months. All right. And this popped up on my Facebook feed and I thought it was funny, so I included it here. Only last night, as I was going over these slides, did I realize that vessel actually stood for like ship, large vessel occlusion. So I got the full extent of the joke last night. But this just goes to tell you that IVTPA sometimes can only scratch the surface of a large clot. And when it comes to a large clot blocking a vessel, we have a new shiny weapon that we can use to help treat a patient, and that is thrombectomy. And you might see us using acronyms like EVT or IAT in our notes, and that all means the same thing: endovascular treatment or intra-arterial treatment. Basically, it is an invasive procedure, kind of like a PCI, where we go in and we physically pull the clot out using either a stent retriever or a suction device. And it has been shown to be very effective. The number needed to treat is basically like 2 to get a patient better. And the inclusion and exclusion criteria is actually less strict for thrombectomy compared to TPA because it's not a systemic medication. So first, you need to be having a disabling stroke. And remember the cortical signs, those are especially the symptoms that we look for when we are deciding which patients to take for thrombectomy. And then you have to have a causative large vessel occlusion seen on CTA. And I included the word causative here because there are instances where you see chronic incidental vessel occlusion that is not causing the symptoms. And then you have to be within 6 hours to go for thrombectomy if you have just a CT and CTA. But now we have the extended window from 6 to 24 hours where you can still take the patient for thrombectomy if you have advanced imaging to help you make that decision. And then according to the guidelines, you do need to consider the patient's baseline functional status in a non-contrast CT. If you see completed infarct on a non-con CT, then that will most likely exclude the patient, even if they're within 6 hours. And if they have a baseline functional status of being wheelchair bound or bed bound for whatever reason, then they're probably not going to be a good candidate for thrombectomy. And nowadays, because of the COVID pandemic, we are intubating all patients who need to go to the cath lab for thrombectomy. So that is another thing to consider. Um, and uh, the extended stroke code, or the extended time window for treatment, um, came into play because of this realization that not all brains respond to ischemia in the same way. So we found that different brains infarct at a different rate, and that range was highly variable. And so some people with a large artery occlusion went on to infarct their brain very quickly. Some people held on and somehow had brain perfusion in that area for longer periods of time, and the brain tissue did not die off for many hours. And so that's why the concept of fast versus slow progressors of infarct became apparent. And so after that realization, um, we switched from time based treatment to tissue based treatment. And this new era of acute stroke treatment dawned, where we look at the tissue and we don't exclude patients just because they're 7 hours into their stroke or 8 hours into their stroke. We go up to 24 hours, and that really dictates our treatment decision. This was made possible by perfusion imaging. So I'm going to talk about stroke imaging. And before I talk about perfusion imaging, I'll go over the basics first. Non-contrast CT. This is the most basic stroke imaging that we get. The first imaging that we get. The first and foremost purpose of a non-con CT is to rule out a hemorrhage. It can show us early ischemic changes. For instance, to a trained eye, there's a little bit of hypodensity and loss of gray-white differentiation in the left MCA territory on this non-con CT. And also we can look for encephalomalacia, old strokes, evidence of prior brain damage. And that gives us additional information. But again, first and foremost, it's hemorrhage that we are looking for and that we're trying to rule out with a non-con CT. And then a CTA of the head and neck tells us if there is a large vessel occlusion. And additionally, it can give us an idea of the atherosclerotic disease burden, the degree of stenosis, and it can give us sometimes the etiology of the stroke. So if a patient has, a lot of calcified ather on their aortic arch or in their carotid arteries, we're probably going to treat them differently than a person who has a dissection, for instance. And it can also show us variant anatomy. Not everybody has a perfect circle of Willis. And so if they have, for instance, bilateral ACA territory strokes, but both ACAs come from one side, then that tells us one thing. It tells us that not necessarily multiple vessels are involved in their stroke. So it gives us a lot of good information. And now perfusion imaging. This is the exciting part. And this is a new modality that helps us with decision making in stroke. And what is perfusion imaging? It's an imaging modality that shows us how blood or contrast flows through the brain. And there is different kinds of perfusion imaging. There's SPECT, there's PET, there's MRI, and there's CT perfusion imaging. I'm going to focus on CT perfusion imaging because that's what we use at UAB. And this is really the exciting new tool that we have. So very quickly touching on the technical parts of CTP, it is a temporal sequence, so shows us pictures over time And these are pictures obtained during the wash in and wash out phase of a bolus of contrast agent. So on this graph, you can see this is as time goes by, you have the influx of contrast and then the outflux of contrast for a specific small unit of brain tissue. And we calculate multiple hemodynamic parameters based on this. And so basically we can calculate the volume of blood within a small unit of brain. And we can also see the flow or volume of blood traversing through that unit of brain during a certain period of time. And we can also calculate the average time required for contrast to traverse that unit of brain. And we can measure the time from start of the scan until the maximum intensity of contrast bolus arrival at each voxel. And so those different parameters give us different information. And what that means on a tissue level is cerebral blood volume or cerebral blood flow gives us the area of infarction or core or dead tissue, basically, where the blood volume within that area or the blood flow within that area is so low that we can assume that that tissue is basically dead. And then the mean transit time or Tmax gives us an idea of the ischemic area or the penumbra, the area that is getting slow flow. It's suffocating but not quite dead yet. So that gives us the core and the penumbra. And so we get this beautiful summary map where the pink tells us dead tissue, green tells us suffocating at-risk tissue. And we compare those two volumes, and if we have a small core in a large area that is left to save, then that would be the ideal patient to take for thrombectomy. So obviously the first and most important clinical application of perfusion imaging is thrombectomy patient selection, but it also serves additional purposes like kind of prognosticating the outcome. If they have a large penumbra and we don't do thrombectomy, they're probably going to have a bad outcome. Detection of ischemic stroke to begin with, identifying the culprit vessel depending on which area of ischemia we see. Sometimes it helps us classify the etiology, and a lot of times it helps us recognize stroke mimics too. Just a few examples of how we use CTP. For instance, this patient had a chronic right MCA occlusion that we saw in a CTA, but it didn't fit with the symptom that they were having. And we found that the actual area of ischemia is in the left hemisphere. So that was one example. Sometimes migraines cause abnormality on a CTP that doesn't respect a vascular territory. And so that gives us an idea that maybe this is not a stroke and actually a migraine phenomena. This is a cardiac arrest patient, and I don't know the details of how this patient ended up getting a CTP during their cardiac arrest, but you can see that the entire brain bilateral and anterior and posterior circulation territories are ischemic. It's not getting blood flow, and we can assume that this is a pump failure, basically. So that was it on perfusion imaging and CTPs. And then MRIs. This is a neurologist's favorite imaging modality. And this helps us identify a stroke. It helps us see the exact size and location of a stroke. It helps us see if there's any petechial hemorrhage that we can't see on a non-con CT. Sometimes it helps us identify the mechanism of stroke. And it gives us a ton of additional information about brain health and pathology. For example, for instance, this stroke, these are pretty tiny infarcts. We would not be able to see it on a non-con CT. Only an MRI can confirm the stroke and the location of the stroke. This is an SWI sequence, and it shows us hemosiderin deposits, and it shows us microbleeds that we would never be able to see on any other imaging modality, but it can help us diagnose cerebral amyloid angiopathy, for instance. And then a FLAIR sequence helps us see, for instance, small vessel white matter disease, and it can help us treat their risk factors a little bit more aggressively if we see a lot of disease there. MRA, they're basically similar to CTAs in that it gives us vessel imaging. The point I wanted to make is that it's different from MRI with contrast. There have been instances where we ask for an MRI and an MRA, and people wrongly assume that the MRA with contrast will get you both, and it doesn't. It doesn't give us any information about the brain tissue. It just shows us the vessels. So I wanted to make sure that everybody is aware of that. Carotid ultrasound and transcranial Dopplers. We're using less of this now that we're getting CTAs for everyone. But it is very useful in that there's no radiation, there is no contrast, it's non-invasive, and it gives us real-time data about the blood flow. We can tap on the vessel, we can press on it to see how the flow changes. And so it does give us useful information, and so there will be instances when we use it. Okay, that was it on stroke imaging. And I will move on to post-acute stroke care in the hospital setting. Blood pressure is probably the most important part of post-acute stroke care. And the thing to remember is that cerebral perfusion pressure is dependent on MAP and ICP. And we definitely want to maintain a good CPP to perfuse the brain in both ischemic and hemorrhagic strokes. And so if you have an elevated ICP, which you normally do with any large stroke or any hemorrhagic stroke, you want to be careful about the MAP. You definitely don't want to drop the MAP too much so that you compromise the cerebral perfusion pressure. And that's why we allow for permissive hypertension in the acute period. We allow the brain to auto-regulate before bringing it down with agents. And there's the blood pressure goal is different case by case. There are some general rules of thumb. For instance, if the patient has an ischemic stroke and they did not undergo any type of intervention with TPA or thrombectomy, then we have a pretty high blood pressure goal and we don't correct it unless it goes above 220/120, unless they have really bad heart failure or something like that, in which case we do shoot for a lower target. After TPA, you want to maintain strictly below 180/105 per the guidelines. After thrombectomy, it's a little bit case by case depending on the result of the thrombectomy, but if you have good reperfusion, then you want to aim for a slightly lower blood pressure to minimize the risk of reperfusion injury. But if you don't have good reperfusion, then you want to shoot for a slightly higher target so that you continue to perfuse the brain while it's dealing with the stroke. If you have a hemorrhage, generally, again, you want to get it somewhere between that 140 to 180 systolic blood pressure. Generally, 160, kind of going for the middle, would be a good rule of thumb for most cases. And then when it comes to supporting a patient through their stroke, we know we have proven data that fever, hypoglycemia, and hypoxia leads to poor outcomes and poor recovery after a stroke. So these are things that we want to pay attention to and treat kind of proactively. And then all stroke patients need to have a swallow evaluation before they are given anything by mouth. Most stroke patients benefit from DVT prophylaxis. Even hemorrhagic stroke patients, after about 48 to 72 hours after stabilization, they benefit from chemical DVT prophylaxis, because we feel that the benefit outweighs the risk. Because if you have a hemorrhagic stroke and then you end up getting a DVT, then you're kind of in a tougher spot. So you want to prevent that from happening. And very, very rarely do we see a worsening of a hemorrhagic stroke due to a DVT prophylaxis dose of medication. Turning and repositioning patients who are paretic or plegic is necessary to prevent pressure ulcers. And for me, from a stroke neurologist perspective, the post-acute stroke care really focuses on these three things: identifying the etiology of the stroke, why did it happen, and then deciding on a treatment regimen to prevent them from having another stroke, because all patients, once they have a stroke, they are at a high risk for having another one. And then guiding them through their recovery. So there's many stroke mechanisms, ischemic stroke mechanisms, hemorrhagic stroke mechanisms. We like to identify a cause. We like to put them in one of these 5 categories if possible, so that they can be on an appropriate regimen to prevent another one from happening. And really, stroke treatment should be tailored to each patient depending on the etiology of the stroke. Hemorrhagic stroke. Again, there's different mechanisms, and you really want to identify why it happened so that we can appropriately prevent them from having it again. And hypertension is probably the most common cause of all strokes, ischemic and hemorrhagic, especially hemorrhagic strokes. Hypertension and cerebral amyloid angiopathy are the top leading reasons for hemorrhagic strokes, probably. And then the rest are much rarer. Okay, and now secondary prevention. I'll start with hemorrhagic stroke again, because it's a little bit more straightforward than ischemic stroke prevention. And that is number 1, number 2, and number 3 is blood pressure control. Can't stress it enough. They need to have good blood pressure control. In a hemorrhagic stroke, there is no indication for starting an antithrombotic or statin. A lot of times we see people who carry a history of stroke and then they get put on an aspirin and a statin because they had a stroke. You really want to identify, was it an ischemic stroke or hemorrhagic stroke? Because for hemorrhagic strokes, you don't want to start aspirin or statin, obviously. And then patients, for secondary or for primary prevention, if they have an indication to be on an antithrombotic, for instance, if they have a stent in their heart, if they have really bad peripheral arterial disease and they need to be on antithrombotic therapy, you want to use it judiciously. And very often we see patients who are put on dual antiplatelet therapy or put on anticoagulation, meant to be for a certain time period, meant to be temporary, for 6 months after their stent, for 3 months after their DVT, and then they just kind of get left on it. And so you definitely want to mark the expiration date for these medications, because they significantly increase the risk of a hemorrhagic stroke. Ischemic stroke prevention. I think the 3 pillars of ischemic stroke prevention are antithrombotic therapy, statin therapy, and risk factor management. These are probably equally important. So I'll talk a little bit about these. And again, I can spend many hours talking just about antithrombotic therapies, but the shortened version is that aspirin is basically the default for ischemic stroke prevention, but anticoagulation is favored over antiplatelets in patients with AFib, mechanical valves, a specific hypercoagulable disorder, or something else that requires anticoagulation. Antiplatelets are favored for most other stroke mechanisms, including cryptogenic stroke. And a lot of people think that anticoagulation is a stronger blood thinner, therefore more effective in stroke prevention, but that's not the case. And just because a patient had a stroke and then had another one while they're on an antiplatelet, that is not an indication to switch to an anticoagulant. You really want to have a specific reason to start anticoagulation. And you can play around with different antiplatelets or really stress compliance with the antiplatelet, but just going from antiplatelet to anticoagulation as an escalation tactic is not recommended because we know that anticoagulation has an increased risk of hemorrhage. And from specific clinical trials, we have additional data that guide our treatment. And we know that long-term dual antiplatelet therapy increases the risk of hemorrhagic complications, and the benefit kind of tapers off after some time. And so you don't want to keep a patient on long-term dual antiplatelet therapy unless they have a really good reason to be on it. We do know that short-term dual antiplatelet therapy can give you additional protection after an acute stroke. For instance, if a patient has ICAD or intracranial atherosclerotic disease, then perhaps dual antiplatelet therapy for about 3 months give you a little bit of additional protection, but not long-term. And for minor stroke or high-risk TIAs, again, the dual antiplatelet therapy for about 3 weeks give you extra protection, and then that benefit tapers off after that. So again, mark the expiration date of the dual antiplatelet therapy. Statin therapy, there was a really big trial called the Sparkle trial that compared atorvastatin 80 milligrams versus placebo in stroke patients, and they saw that patients on this high intensity statin had fewer recurrent strokes, fewer coronary events. And so it is recommended to put ischemic stroke patients on statin therapy, on high intensity statins. We believe that not only does it lower cholesterol levels, it also probably has pleiotropic effects that helps keep a blood vessel healthy. And then risk factor management. Like I said, I think all three pillars, the antithrombotics, the statins, and risk factor management, they're all important, but the risk factor management is something that requires the most effort on the patient's side. Pills, it's easy to take pills, but this really requires the patient to change their life. And so it's probably the hardest part, but it is very, very important to treat their underlying risk factors, to quit smoking, to eat a healthy diet, to exercise, to get them on their way to health and recovery. And that concludes my talk. Please ask me any questions.
I don't have a question, but I just want to say that the new imaging that you talked about is fascinating.
Yeah, perfusion imaging, that really has opened up stroke treatment to, from being something that we can only do in a few hours to, the extended time period, 24 hours. So that has been an exciting change in stroke.
Thank you for adding that and to show the images, the different perfusion images. That was very helpful.
Good. I'm glad it helped. And I actually gave a grand rounds talk on perfusion imaging. So if you want a more detailed talk on that topic, I would be happy to give it.
Just a second question on imaging, and this is just for everybody. We have a lot of different people on the talk now. You mentioned the MRA and the MRI. Can you just talk about the MR stroke protocol, just so everybody's on the same page about how stroke protocol kind of encompasses everything, and also on timing, if there's ideal timing for obtaining the MRIs?
Sure. So MRI stroke protocol is just a bundle that we have at UAB, and that includes MRI of the brain, usually non-contrast unless you specify with contrast, and then MRA of the head and neck. The reason that we have that bundle called MRI stroke protocol is because it's cumbersome to order all three things, and so it puts it in one order set. And in most cases, if you already have a CTA, then you don't need additional MRA unless you specifically are looking to, double check something. If you have a CTA, just go ahead and order an MRI brain, either without or with and without contrast. But if you don't have a CTA and you're, evaluating the patient for a stroke, then go ahead and get an MRI brain, MRA head and neck or stroke protocol to get you all of those information. Oh, and then timing. If a new neurologic deficit is found acutely, and if you're within that 24-hour treatment window, then obviously call a stroke code, and that will give you CT, CTA, and CTP in most cases. And the MRI, it's very hard to get a stat MRI, and even if we order it stat, and even if we call the MRI tech, it still usually takes an hour or two to get the MRI. And so we try to make a decision on acute intervention based on CT, CTA, and CTP if possible. If we absolutely need an MRI, then we'll have to get it as a stat imaging, but we usually rely on CT for decision making in the acute period. And then the MRI is just kind of after all of that has been said and done to confirm location and size of the stroke. Yeah. Does that answer your question? Okay. What other questions do you have?
Well, if there's no other questions, I know as we get in further into the partnership and as we take more stroke patients, I'm certain there will be topics that emerge that the team will request. So we will likely invite you back for additional talks if you're willing. I think the blood pressure management will become something that a lot of people do have questions about as we share these patients going forward. So that may be one area that we can focus a little bit more. I know a lot of night people were on here, a lot of people who are going to be cross covering all these patients. So we can gather some of these questions as we go forward.
Sure.
Any other questions from anybody else?
I guess that would be one question that I have is outside of the ICU setting where you're using drips and things like that to, obviously we're not going to have the ability to do drips that you might prefer when your patients are in an ICU or a step down unit. So are there blood pressure agents that you like to use in an acute care setting?
In the acute care setting. When it comes to PRNs in stroke patients, it's basically labetalol and hydralazine. Yeah, those are probably the PRNs of choice. And then oral medications. this is a part where we ask for help from our hospitalist colleagues, mm, depending on the patient's renal function and age and other comorbidities. That kind of decides which regimen we use. Yeah.
And I think a lot of it will be because of the different types of strokes we'll be managing, having clear blood pressure goals.
Mhm.
Make sure that we're all on the same page.
Yep.
Okay, well, I think that we're gearing up for our team hall in a few minutes. Thank you so much for your time and coming to speak with our service. If anybody
Yeah.
else has questions, feel free to send them our way. Otherwise, we will likely see you again in the future.
All right.